good afternoon, good evening. If you are just joining us now, we welcome you to our ICAP Grand Rounds. We're going to allow another minute for additional folks to join. So please just uh, stay tuned. Okay. Um, Good morning, good afternoon, and good evening. Welcome to ICAP Grand Rounds. I am really pleased today to uh, get our session started on cryptococcal meningitis. We have two speakers who are really experts who are going to be talking to us about cryptococcal meningitis. We will certainly hear about it in more detail, but this is an important fungal infection. It's a leading cause of morbidity and mortality globally, especially among people with advanced HIV disease. Cryptococcal meningitis accounts for over 100,000 HIV-related deaths per year. And access to treatment, and particularly sustainable access to treatment for cryptococcal meningitis, unfortunately remains a major challenge in low and middle income countries due to the lack of availability of the necessary diagnostics and antifungal medications. So today we have an expert from Columbia University and an expert from the University of Minnesota who are going to review cryptococcal meningitis in the context of these settings and explore data on screening and management gaps. We're going to first hear from Dr. Radha Rajasingham. Dr. Rajasingham is an infectious disease physician and associate professor of medicine at the University of Minnesota. Her primary research interests are to maximize the public health impact of screening HIV-infected persons for opportunistic infections, such as cryptococcal meningitis, in order to decrease HIV/AIDS-related mortality. And she conducts clinical trials in Uganda to evaluate new diagnostics and prevention strategies to reduce AIDS-related deaths among people living with advanced HIV disease. After Dr. Rajasingham speaks, we will also then hear from Dr. Kiran Thakur, and I will introduce her after Dr. Rajasingham has finished her talk. So, Radha, please go ahead. And just one note that if people can put their questions for the speakers in the Q&A box, that would be really helpful. We'll keep an eye on that Q&A box. We'll try to monitor and respond to anything that we can in real time, and otherwise we will save those for the Q&A session at the end. So, Radha, thank you.
Thank you so much. Hi, everyone. Thank you so much for joining. Just going to turn my video off. So today I'm going to speak with you about cryptococcal meningitis and also talk about both treatment and prevention in low and middle income countries. So we'll do an intro to cryptococcal meningitis for those of you who don't think about this regularly. We'll talk about new treatments that are available, prevention strategies, and new prevention strategies that are being researched right now. So to start broadly, there's an international goal to end AIDS-related deaths. And this is a depiction of how we hope to do that. So the hope is to end AIDS by 2030. And the goal for 2020 was to get 90% of people aware of their HIV status, of whom 90% should be on HIV treatment and 90% should be virally suppressed. Once you have 90% virally suppressed, this reduces new HIV infections and also should reduce AIDS-related deaths. For those of you who are based in America, this isn't just an international goal, but this has also been a priority in the US historically. So how are we doing so far? So this is a map of a graph of AIDS-related deaths. And on the x-axis, you have years. And what you can see is AIDS-related deaths peaked in 2004. And in 2023, there were 630,000 AIDS-related deaths. So to give you some context, the goal was to have less than 500,000 AIDS-related deaths in 2020. So we missed the mark there internationally. And the goal for 2025 is to have less than 250,000 AIDS-related deaths. So we're kind of primed to miss the mark on that too. So why are there so many AIDS-related deaths and what are people dying of? At this point, I'm going to introduce the term advanced HIV disease, which is a little bit more of a descriptive term of people who have a low CD4 count or who have AIDS-related diagnoses. So moving forward, I'll use advanced HIV disease to speak about people with low CD4 counts. And surprisingly, despite improved access to HIV treatment across the world, still 30 to 40% of people who come to HIV clinic to start treatment in low and middle income countries have advanced HIV disease. These people are very vulnerable population because they're at high risk for infections and death. And I've listed the causes of death here in this population. The number one cause of death in advanced HIV disease is TB, followed by cryptococcal infection, and then bacterial infections. So today we'll talk about cryptococcal infection exclusively. So what is Cryptococcus? Cryptococcus is a fungus that exists in the environment. Typically, people acquire it from bird droppings or tree bark, and they inhale it. And if you have an intact immune system, it can be contained in your lungs. However, if you are immunocompromised, it's hard to contain that fungus in your lungs. It can spread to your blood and then to your brain. This is what the cryptococcal pathogen looks like under a light microscope. So people do India ink microscopy, and then there's this really thick capsule that can be seen through the light microscope. And so this is kind of a classic picture of cryptococcus. The symptoms of cryptococcal meningitis are kind of normal meningitis symptoms. I think what's unique about cryptococcal meningitis is frequently it's a subacute presentation. So frequently people present with over 1 week of headache. And it's this kind of on again, off again, sometimes present, sometimes not headache. And it's not like a rip-roaring presentation of bacterial meningitis. It's more of a subacute presentation. However, if people present very late to care, they can present with coma and die very quickly. This slide summarizes the causes of meningitis among adults in Africa, and each row represents one cohort from a different country. And the main point of this slide is to show you that cryptococcal meningitis is the number one cause of meningitis among people with HIV. So this isn't just some um, esoteric thing that people research and we talk about in these scenarios. This is actually something that we see very commonly in HIV endemic settings. And as was mentioned in the introduction, cryptococcal disease causes 19% of AIDS-related deaths. And you can see the majority of the cases occur in sub-Saharan Africa. And mortality in routine healthcare settings or in routine settings in sub-Saharan Africa has been estimated to exceed 50%. And so why is that? Why is mortality so high in this population? So historically, it's been hard to diagnose. It requires people to actually present to facilities where they have lab capabilities. Antifungal medications are hard to access, especially in low and middle income settings. If you do access them, they have their own toxicities that need to be managed. Um, Skipping to supportive therapy, people who are on amphotericin, which is the main antifungal medicine, need IV fluids and electrolyte management. Otherwise, they can still have poor outcomes just from the medication itself. This is a unique disease in that people require therapeutic lumbar punctures to reduce pressure around the brain, which also requires a good amount of healthcare worker resources. And so, if we could come up with shorter, less toxic regimens, that would really improve survival in this population. Just so you can see what access to some of these antifungal medications are in the places where the burden of cryptococcal meningitis is highest, you can see here that flucytosine, which is considered a critical medication for this disease, is really not very accessible in Africa at all. Similarly, access to amphotericin, the red indicates some level of access, is frequently not widely available. So we're going to talk about a shorter, less toxic regimen that was recently explored because this is probably the biggest finding in cryptococcal meningitis in the last few years. So this is specifically the AMBITION trial, which was a phase 3 randomized clinical trial to evaluate single-dose liposomal amphotericin for the treatment of cryptococcal meningitis. So historically, the treatment has been amphotericin deoxycholate plus flucytosine with fluconazole. So the pros and cons of that medication regimen are that they tend to be quite effective. But as I was alluding to earlier, amphotericin has a nickname of amphoterrible because it causes really severe kidney injury, anemia, and what can be life-threatening hypokalemia if it's not managed appropriately. So the intervention here, or the experimental regimen, was one high dose of liposomal amphotericin, and then participants would get oral flucytosine and fluconazole as well. This clinical trial occurred in 5 countries in Southern and Eastern Africa. People who were eligible were people with HIV who had a first episode of cryptococcal meningitis, and the primary endpoint was death from any cause at 10 weeks after randomization. The baseline characteristics are listed here. The team was able to randomize 844 people with HIV-associated meningitis. Things to note about the baseline characteristics, the median CD4 count was 27. So this is a really immunocompromised population. 30% of people had a new diagnosis of HIV, and 65% had prior exposure to HIV treatment. And just skipping to the results, what you can see is all-cause mortality at 10 weeks was non-inferior with liposomal amphotericin, as is shown in the orange, compared with the standard of care that's shown in the blue. Even more interesting was that grade 3 and 4 adverse events were lower in the intervention group compared to the standard of care group. So the conclusion here is that for HIV-associated cryptococcal meningitis, single-dose liposomal ampho is non-inferior to the standard of care and is associated with fewer adverse events. So this was quickly incorporated into the 2022 WHO guidelines, and single high-dose liposomal amphotericin is part of the preferred regimen for cryptococcal meningitis. One question that is inevitable is that's great that they did this in a clinical trial. Is this really feasible in the real world? Is it really, can you get the same outcomes in a real world scenario? And this was studied by our group in Uganda, where they analyzed an observational cohort of people with HIV-associated cryptococcal meningitis and observed equivalent 10-week survival compared to people in the clinical trial. So now we're going to move into cryptococcal prevention. And so we've talked about cryptococcal meningitis being this devastating illness for people who are in low and middle income countries, mortality is very high. So if I told you there was a way to prevent cryptococcal meningitis, that would be something that everybody would want. And the good news is it can be prevented. Cryptococcal antigen can be detected in the blood before people have meningitis, and it's a strong predictor of developing fulminant meningitis. So moving forward, I'll call cryptococcal antigen CRAG, and we'll use that short form moving for the next few slides. So I showed you this progression of how people inhale the organism, it goes to the lungs. And when we're talking about prevention, we're talking about stopping it before it gets to the brain. So it's traveled to the lungs and into the blood, but it's not yet in the brain. And so a group so our group earlier in 2010 published an observational study where they observed outcomes for 33 people with cryptococcal antigenemia. So cryptococcus in the blood, but not yet in the brain. All of these people got HIV treatment, but the people who received fluconazole had significantly better survival than people who didn't get fluconazole. And this is sort of borne out in a randomized clinical trial where they evaluated cryptococcal screening and preemptive treatment. And so they randomized 1,999 people in Zambia and Tanzania to cryptococcal screening and community support versus standard of care. And what they found was a 28% relative reduction in mortality with cryptococcal screening and community support. So that was enough to influence WHO recommendations. And so the WHO recommends cryptococcal screening for all adults with the CD4 count under 100. And if they're found to be positive, they get the following fluconazole regimen. Interestingly enough, despite this fluconazole, a person with cryptococcal antigenemia, if they get HIV treatment and fluconazole, their mortality is still higher than that of a CRAG negative person. And the question is why? So this is an area that I find really interesting. Our group has studied this and tried to understand who's at risk for meningitis and death among all these CRAG positive people. So in summarizing 4 prospective cohorts from Africa of people with cryptococcal antigenemia, what we found is people with high CRAG titers in the blood are at increased risk of death despite receiving HIV treatment and fluconazole. So the inevitable question is fluconazole good enough? Should we be giving people fluconazole? Should we be using a higher dose for longer? Or should we be trying a different regimen? Should they get treatment for cryptococcal meningitis to improve their survival? So other regimens that are being considered are flucytosine and fluconazole. One could consider amphotericin. And then we're also considering liposomal amphotericin in a one-time dose. One thing I'd like to say before moving forward is that these are healthy outpatients who come to HIV clinic, and then after clinic, they want to go to work. These are asymptomatic people who don't feel sick. And so it's really hard to give someone amphotericin in this situation because they're not ill and the medication will make them feel ill. They do not need to be hospitalized. They don't want to be hospitalized. So we need to think about regimens that are more effective, but also can be given in the outpatient setting. I'm going to spend the last few minutes talking about the Acacia trial, which is a clinical trial that I run in Uganda, where we're testing single-dose liposomal amphotericin for people with cryptococcal antigenemia. And the premise is, if single-dose ambisome is safe and effective for the treatment of meningitis, shouldn't we be using it or considering it to prevent meningitis for people at high risk? So this is a randomized clinical trial where we randomize participants with cryptococcal antigenemia to one dose of ambisome plus fluconazole versus fluconazole alone. And this is what the randomization looks like. Then they get followed up. They start their HIV treatment, and we assess 24-week survival. So the primary outcome is 24-week meningitis-free survival. We're also looking at safety, tolerability, neurocognitive outcomes, and then also the cost effectiveness of this regimen. So thus far, we have enrolled we've enrolled 210 people. Our goal is 356. This is a clinical trial that's occurring at 6 sites around Uganda, primarily based in Kampala, but we've branched out to other regions. And I wanted to show you and have you think about what a clinical trial for cryptococcal screening looks like. These are the clinics that we work in. And these are the labs where cryptococcal screening occurs. Often in these labs, there's also TB testing, CD4 testing, malaria testing, and all of the other labs that people need when they come to HIV clinic. So this trial and cryptococcal screening in general requires a referral model. So people need to be screened, referred to a central site, and then screened for the study. So what are barriers to cryptococcal screening? So the WHO recommends screening for people with a CD4 under 100. So that requires people to get CD4 testing. So if CD4 testing is not performed, they likely won't get cryptococcal screened. Sometimes cryptococcal screening isn't performed correctly. And then thereafter, participants are sometimes hard to contact if they go home. It's important that they get screened and treated all on the same day. And then sometimes guidelines recommend that a lumbar puncture is done even if they're asymptomatic. And this is a huge source of stigma in our patient population. So patients aren't always willing to come in if they think they may need a lumbar puncture. Some quick preliminary results before I close. So what we found so far in our clinical trial is that actually there's no benefit for single-dose amphotericin in people with a low CRAG titer. The Data and Safety Monitoring Board stopped us from enrolling low titer participants. And so we were able to publish that there was no benefit to liposomal ampho and low titer participants, mainly because very few of them were getting meningitis and dying, and essentially 90% of them were surviving. So moving forward, we're enrolling only high titer people, we're performing neurocognitive testing, and also will perform a cost effectiveness analysis. So just in summary, to remind you that cryptococcal meningitis is a devastating illness with high mortality. It's the #2 most common opportunistic infection, in people with advanced HIV disease and the most common cause of meningitis. Single dose ambisome is first line therapy for the treatment of cryptococcal meningitis. Cryptococcal meningitis can be prevented, and clinical trials are underway to refine CRAG screening treatments. Thank you so much.
Great, Yada. Thank you so much. That was really wonderful. And I know I have a question or two, and there's at least one question in the Q&A. So we'll get to those at the end, and just encouraging people, if you do have questions, to go ahead and use the Q&A box. So now we'll move to our second talk. We have Dr. Kieran Thacker, who is the Herbert Irving Associate Professor of Neurology here at Columbia. And she leads the program in neuroinfectious diseases and the program for community and global neurology. In addition to her work at the Columbia Medical Center, Dr. Thacker performs clinical and implementation research studies internationally. We're going to hear a little bit about that today. She also serves as a consultant with WHO and the Pan American Health Organization. Kieran, thank you.
Thank you so much. Thank you for the kind introduction. And I think this Dr. Raja Singham has really set the stage in terms of some of the cutting edge research that is being done by her group and others. And I'm really going to tackle the kind of how do we actually get this to the bedside. So I'm going to go ahead and stop my video and share my screen. So I'm really going to focus on how we implement cryptococcal meningitis guidelines, some of the challenges and opportunities, especially amongst vulnerable populations. And I'll speak to some of our ongoing work in partnership with our Ethiopian colleagues. These are my disclosures. So I want to first start off by acknowledging my colleagues in Ethiopia that have been really just incredible to work with. We are working with a team of physicians at this hospital on the upper corner on the right, Eider Hospital, which is the second largest hospital in Ethiopia, serving over 9 million individuals, thousands of individuals with HIV, which was at the epicenter of the civil war that occurred in northern Ethiopia between 2020 and 2022. And this has really been an incredible partnership that I've learned so much from colleagues who are on today, as well as colleagues in ICAP, ICAP in Ethiopia, led by Dr. Zanebe, who hopefully we'll hear from as well, which has done an incredible amount of work I'll speak to in terms of rebuilding some of the HIV care in the region post-conflict. So as we just heard, there is an incredible amount of positive evidence with respect to how we prevent, how we diagnose rapidly, and how we treat cryptococcal meningitis effectively. But the issue is that across many conditions, including cryptococcal meningitis, the evidence doesn't really trickle down into practice. And so there's been studies in resource-rich settings that have shown that it takes upwards of at least 20 years for research and evidence-based medicine to actually reach the bedside, and only approximately 10% really reaches patient care. And that's likely even much lower, as we know, in low-income settings. And so the question is how, why, and how do we actually fix that gap that exists between evidence and practice? So we know that there is this excellent evidence that has been put together in terms of international guidelines for how we prevent, diagnose, and manage cryptococcal disease amongst adults and adolescents, children living with HIV. Yet, as we just heard, cryptococcal meningitis remains a huge burden, especially in the sub-Saharan African region, and is a major driver of deaths in people living with advanced HIV. So why is evidence-based guidance not used? I love this kind of pictogram that shows these various factors that are really at an interplay. And there are many factors in terms of why we don't see evidence-based guidance actually trickle down into bedside medicine. I'll speak to a few of these, but we really are trying to study all of these in the setting of cryptococcal meningitis at Eider Hospital. One is the political and social context. Next is the kind of health organizational system context. The clinical practice guideline context. So is it usable? Is it adaptable? Is it relevant to populations, which is vital? We often don't think about that when we're actually developing guidelines. What about health professionals? Is there competence and knowledge? What's the attitudes and behaviors? And then the patient context, which I think is so vitally important that we oftentimes neglect to study and evaluate. So in terms of national policies, we heard about the evidence that exists with cryptococcal antigen screening. And though it's been now over a decade since the development of cryptococcal antigen lateral flow assay, which is essentially a very rapid test that can evaluate for cryptococcal antigenemia, and the inclusion of cryptococcal antigen screening in international guidelines, we know that there are many countries that are not actually implementing these. And so we can see here there's still major gaps, including countries across sub-Saharan Africa that do not even have the cryptococcal antigen screening guidelines. And there's various thresholds in terms of when, how to treat, and the thresholds of CD4 counts. I think another major issue, which ICAP and others are addressing, is the lack of CD4 testing across many regions internationally, including sites in Ethiopia. And hopefully with improvements at advanced HIV protocols, we can improve upon CD4 testing, and then that will allow for cryptococcal antigen tests. There are many, many factors of why preemptive screening is not done in treatment, including laboratory and drug shortages, high loss to follow-up in patients and providers, issues with communication of laboratory results, and appropriate clinical action. So we've worked with the HIV Policy Lab as well as ICAP to understand where things stand with respect to policies around cryptococcal meningitis prevention, confirmatory testing, and treatment. And this is some of the data that has been published, now about 1 year old. We've recently updated the data with respect to country and national policies that are in each of these domains. And really what I want you to take away from this is that you can see the kind of lack of blue color and this transition of orange to yellow color, meaning that there's no adoption or partially adoption of evidence-based guidelines in countries as you go down in each of these pathways from screening, prevention, confirmatory testing, and treatment. So the largest gaps at a policy level really are happening at the treatment standpoint. And I think a big question is why? Why do those exist? Is it around drug availability? Is it around the inability to monitor for adverse events, which we heard about in terms of the clinical trials? We really need to kind of understand this further. So I'm going to speak a little bit about the work that we're doing in partnership with colleagues at Eider Hospital, which, as I mentioned, is this vulnerable kind of post-conflict setting. And I think I want to really highlight why these vulnerable populations are so important to study in the context of HIV disease. One is that individuals who are in conflict or emerging from conflict are a huge global population worldwide. And so to ignore them and to not evaluate implementation strategies is really to kind of not address the gaps that exist within HIV care. So I think some of these numbers are pretty striking. 1 in 6 people are estimated to be exposed to conflict globally so far in 2023. There are 50 countries that have been flagged at the most extreme or high levels of conflict. And there's been a 27% increase in political violence incidents in the past 12 months. And you can see here many of the global populations that ICAP does work in, as well as organizations where there's high burdens of HIV disease, are areas of ongoing extreme levels of conflict. So what is the impact of conflict on advanced HIV disease? I mean, this is a talk in and of itself, but I just want to mention briefly that it's complex, but what we have identified in northern Ethiopia is that there's been a huge surge in poorly controlled, untreated HIV, as well as new HIV infections. Some of those factors related to the impact of conflict includes the increased risk of sexual violence and weaponizing HIV, the increase in risky behaviors due to socioeconomic instability, a major disruption in healthcare access, including access to antiretroviral medications, the issues around population mobility, and then psychological distress, which is obviously a huge major player. So the civil war in the Tigray region in northern Ethiopia, shown in the maps here on the right, occurred between 2020 and 2022. This was an area that was really making marked improvements in HIV care and was a kind of a pillar of HIV care internationally before the war. Essentially, healthcare in this region completely shut down, although physicians and healthcare workers remained and tried to care for this very vulnerable population during the war, including my colleagues. So what happened to HIV care in northern Ethiopia? So shown here on the right, and this is a remarkable study I hope everyone reviews. This was a study that looked at the impact of conflict in rural areas in the Tigray region in 2020 when the war emerged. And what they found was that there was this massive drop in HIV follow-up, laboratory service, and treatment of HIV when you go down to almost single-digit numbers for the amount of follow-up laboratory services and HIV treatment during the kind of highest degree of war. What was identified is that there was a disruption of over 90% of essential HIV and neurological care services. As I mentioned, sexual violence is one of the drivers of new HIV infections. And what they found in the region was that over 10% of survivors of sexual violence tested newly positive for HIV. As I mentioned, there was a collapse in terms of healthcare infrastructure, with over 70% of hospitals, 80% of healthcare centers, and 712 health posts, which are really the areas where we see a lot of HIV care emerging, were non-functional. And there was an exodus, unfortunately, of trained medical professionals who were oftentimes the target of violence. So what has been done in terms of the aftermath of this conflict? And ICAP has really been at the center of trying to rebuild HIV care with Dr. Zinebe and the team really providing a huge amount of support to rebuild the care amongst individuals with HIV. So there was a rapid assessment done by ICAP and the Ministry of Health in terms of restoration of antiretroviral services, and then the rapid development of an operational plan. There was an emergency response team that recovered electronic medical records to try to track patients. And then there was support for the purchase and distribution of medical equipment that had either been lost, stolen, or destroyed, and other critical supplies. And then amazingly, there's been restoration of HIV care due to this work in over 65 health facilities. Viral load testing has gone from 48% at the kind of end of the war to over 90%. So there's been really, I think, huge successes as well. What has also been happening and what's related to cryptococcal meningitis care is that there's new, I think, momentum both nationally in Ethiopia, but also globally, with really addressing what I would call a neglected disease, which is advanced HIV disease. And so there's been international guidelines that have been developed that have identified how we actually monitor for advanced HIV disease, including the importance of CD4 testing, and also monitoring and screening for conditions like cryptococcal meningitis and tuberculosis. And so we really have been able to leverage what's been going on nationally with AHD guideline integration to really format a study that hopefully will improve cryptococcal meningitis detection, diagnosis, and treatment. So one thing that our team has done, and many of the members are on this call, is to try to understand nationally kind of where healthcare workers are in terms of their knowledge, attitudes, practices, availability of diagnostics for cryptococcal meningitis. So we did this survey in 9 centers across Ethiopia, including Eider Hospital in northern Ethiopia. We've surveyed now over 300 healthcare workers. And I think what it shows is just kind of the disparities in what we think evidence-based medicine shows and the gaps that exist in terms of where healthcare workers are in terms of their understanding. So you can see here that there's still a lot of questions around policy support, the availability of standard operating procedures to facilitate guideline adherence, the lack of continuing education. And then in terms of the availability of diagnostic assays, we also surveyed pharmacists and microbiologists across these settings. And what we identified is that there's huge gaps in terms of the basic materials that exist to diagnose and manage cryptococcal meningitis, as well as other neurological conditions in these regions, including the basic, what I would say, tool that we use in neurology, which is the lumbar puncture kit, as well as cryptococcal antigen specific assays. And why is a lumbar puncture important? So as was mentioned in the last talk, we take off fluid called cerebrospinal fluid so that we can evaluate, one, for conditions like cryptococcal meningitis, but we can also manage the disease because we can take off a lot of fluid, and that actually decreases the pressure in the brain and leads to decreased mortality associated with cryptococcal meningitis. And so what we call therapeutic lumbar punctures, where we take off a high volume of cerebrospinal fluid, is really a fundamental part of our management of cryptococcal meningitis. So in addition to all of the treatments that we have, the antifungal treatment, we also want to be decreasing that fluid pressure. But if we can't perform lumbar punctures, then we can't actually do this. And this is a fundamental gap in terms of our ability to treat this condition. So this was work, and some of the work that we had done kind of early on when I was a fellow actually trickled down into other collaborations that occurred. Actually, this is a study that was from Zambian colleagues that looked at what we call the TAP gap, which is why lumbar punctures are not performed, which is really a major issue globally, but specifically in sub-Saharan Africa. And it trickles down from patient understanding to provider understanding to lack of laboratory support, and then a lack of availability of treatments, as you can see, and why we don't do such a fundamental test that we have for neurological conditions. So some of the work that we also have done, and I want to invite Dr. Nurve to comment on this after we speak, is really speaking to healthcare providers, both in the HIV clinic as well as in the inpatient setting on, at Eider Hospital, what are some of the gaps in terms of care? So we did these qualitative interviews, and we're continuing to do this work to really understand what we should be addressing and how we should be addressing some of these gaps. One is the kind of impact of armed conflict on HIV care. So we know that there was a lack of access to HIV drugs. Some of the challenges that are specific in cryptococcal meningitis diagnosis. So I think this is an important quote to read. We still don't have lumbar puncture sets. We have heard from our colleagues, we use intravenous cannulas to perform lumbar punctures. And the results we get from using these intravenous cannulas are unreliable. And then another, we don't have proper India ink staining. And so we often use our clinical judgment to start treatment. Training gaps. So I think this quote, I've had orientation training once on cryptococcal meningitis, which was not enough. And I had to update my colleagues back in the hospital. And then the psychological impact, which I don't think can be ignored. After we go home, we cannot stop thinking about the war. We are all still traumatized. Another part of our study that we did, that we performed as preliminary data, was really to look at what was happening with HIV care before the conflict, during the conflict, and post-conflict, and how that was trickling down into cryptococcal meningitis prevention and then diagnosis. And as you can see here, there's a huge gap even now in terms of our ability to look and screen for cryptococcal meningitis in individuals who meet this criteria of CD4 counts less than 100. And I think you're starting to make headway to see that there's a few patients that are actually kind of going down this proper cascade of care, but we have major gaps to fill. So, what are our next steps? I just want to spend the last few minutes describing what we're planning on doing. So, we've put together a proposal in close collaboration with colleagues so that we can understand what some of the factors are in terms of some of the internal processes, some of the patient-related outer setting processes, and then some of the innovations that we can develop in terms of novel testing and simulations for lumbar punctures, the availability and access of kits and training materials so that we can really provide holistic care, which some of our Ugandan colleagues have really been at the forefront of doing. And then we want to really leverage what ICAP has already done for HIV care and build that around cryptococcal meningitis. So without understanding the processes and gaps that occur through data registry, we really cannot understand how to actually address those gaps. And so what we recognized in looking at the retrospective data through chart review is that there was really a lack of understanding of where the gaps were in terms of cryptococcal meningitis prevention and diagnosis. And so we're developing this data registry, and we're also in conjunction and parallel with that, proposing that we actually have training programs so that we can have data analysts locally to actually address and sustain these data registries for cryptococcal meningitis. So that was a whirlwind. I think hopefully we've provided you evidence that cryptococcal meningitis is a major driver of death in people living with HIV. And I think a major pillar for us to really understand how we can hopefully achieve these substantial goals in advanced HIV disease. Conflict settings amplify the disparities in HIV care. They require highly coordinated, specialized assistance across multi-level stakeholders. And hopefully we'll hear from Dr. Zenebe after I speak about some of the work ICAP is doing locally. And that these coordinated efforts to implement cryptococcal antigen screening protocols and improve rapid diagnosis and treatment are very urgently needed, and that we need to provide technical assistance, but we also need to provide training support, and we need to understand kind of how all of these factors interplay to really improve outcomes at the bedside. Thank you very much.
Wonderful. Karen, thank you so much. So we've had two great talks. I want to just call everybody's attention to the Q&A box. If you haven't already looked at it, there have been almost a dozen questions, most of which have been answered live. Thank you very much, Dr. Raja Singham, for doing that. I think there are some really interesting questions, but let's go ahead and hear from some of our colleagues in Ethiopia. Kieran, I'm going to let you moderate this part.
Yeah, so I would love to first have Dr. Zenebe. Hopefully, we can hear you and you can speak on some of your work that's ongoing in terms of rebuilding care regionally and some of the, I think, incredible efforts that you've done in Ethiopia with respect to advanced HIV and cryptococcal meningitis.
It looks like Dr. Zeneva dropped off. So
Ah, okay.
let's,
Okay.
while he's trying to rejoin, perhaps we can go. Did you want Dr. Nourier to speak?
Yes, if he is on as well, I'm just looking to see whether he has also. Oh, Dr. Zanebe is back. I'm not sure. And Dr. Temiscan, yeah, why don't you comment on some of the work that you've done with these qualitative interviews? We'd love to hear more.
Okay, great. Thank you. Can you hear me all?
Yes.
Yeah.
Okay, so my name is Namaskan. I'm a neurologist from Ethiopia. I'm coordinating the project, the capacity building project that's being conducted at Eider Hospital. So as part of the project, we started conducting qualitative interviews to care providers at Eider Hospital. And what we have found is, so we tried to get their sense of the healthcare service, particularly related to HIV and cryptococcal meningitis, comparing prior to the armed conflict, during the armed conflict, and in the aftermath of the conflict. So what most of the respondents agreed is, so the conflict massively disrupted the healthcare system, which made particularly the care of HIV and cryptococcal meningitis most vulnerable. And so most of the patients were unable to get, the antiretroviral medications during the war. So as Dr. Thakur rightly pointed out earlier, so the HIV care system, healthcare system at Aider was pretty strong before the conflict, but that was totally disrupted during the war. So that led to a lot of serious consequences to patients and healthcare providers as well. So patients were not even able to get, let alone CD4 and viral load testing. They were not even able to have the basic CBC and, organ function tests. And patients were, so some of the respondents, almost, yeah, 90%, I would say nearly 90% of the respondents told us that so some of the patients were even taking antiretroviral drugs whose expiry date had passed, and some were dying with shortage of medications, including heart. So it was a very difficult and challenging situations for healthcare professionals during that time. So one of the respondents also said that even the families of diseased individuals were bringing the ART medications for other patients. So this shows how it was, traumatizing even for healthcare providers and also the families of the patients. So yeah, and as it was also mentioned, there was people were missed from follow up, and so what we interviewed, nurses and also uh, consultant neurologists, internal medicine residents, and so on. And so they were telling us just right after the cessation of the hostilities and the restart of the service, they were seeing an increase in the number of HIV patients and also patients who were admitted with HIV stage 4 disease. So that also shows how the situation was really tough. Yeah, so by the way, so the qualitative interview is still being conducted, it's continuing. So this is what our preliminary data from the interview showed. Thank you so much.
Great.
Thank you, Dr. Thomas Scan. I think that's really valuable. Should we, Dr. Zanebe, are you able to speak now? I know the connection was, we would love to hear from you if you're available. Ah,
Can you hear me?
Yeah.
yes, we can hear.
Yes.
Great. Thank you so much for the excellent presentation. So ICAP has been the lead implementing partner supporting the Ministry of Health the introduction of advanced HIV disease management, which includes cryptococcal meningitis. So in 2022, ICAP supported the ministry in adopting the WHO recommendations regarding cryptococcal screening management. So now it's part of the national guideline. And following that, we support the development of training materials. And we support the ministry to provide training of trainers. And then we support the Regional Health Bureau to roll out the training to regions and health facilities across the tier system. And now the last 1 year, we have been working closely with Ministry, PFR, CDC, and through Ministry with Global Fund in quantifying the required supplies for cryptococcal screening management. So, cryptococcal screening supplies have been imported last year. And now those screening tests has been distributed to health facilities. Similarly, cryptococcal medications, including liposomal and amphotericin B and flucytosine, has been purchased and distributed to health facilities. So we have supported Ministry to develop a phased plan because it's very difficult to reach at all nearly 1,500 health facilities at one go. So phase one, we have selected high impact sites, big hospital health center using a hub-spoke model, and we have supported rollout of this, after we train individuals, availability of making sure that the supplies cryptococcal screening are available, the cryptococcal screening and then cryptococcal management, and that it has now those services are available at 291 first phase health facilities. As we speak, we are expanding to phase two health facilities, additional 300 facilities. So that work has started. And during this process, one thing we have noticed is many facilities, they don't have LP sets. So we have purchased at least LP set for the first around first phase health facilities. Now, as we speak, we are distributing LP set high impact, around 290 phase one facilities across the country. And we this provision will help alleviate the challenge in conducting LPSAT, as it has been noted by Dr. Thakur. So, and during this process, we have helped the system to have a data management system to see the cascades, the fact that all patients, HIV positive will have a CD4 test and screen for using WHO staging. Those who fulfill the criteria for advanced HIV disease will have, particularly those less than 100 CD4 count, will have cryptococcal antigen screening. Those identified positive will be clinically evaluated. Those asymptomatic ones will be receiving fluconazole treatment, and those symptomatic ones will have an LP. And based on the LP result, say safe, they will have cryptococcal antigen test and additional tests on say safe. And those who turned positive will be started on treatment because now treatments are available in country. But this is a new introduction over the last 1 year. So there is a lot of significant progress, but still there is a lot of work to be done to optimize care for patients with cryptococcal meningitis, particularly now, even if we introduce lumbar puncture, but say safe measurement facility was there, and there is a need to build capacity, as has been noted by Dr. Thakur, to build the capacity of the providers and their confidence in providing optimal care for patients with cryptococcal meningitis. And we are really very much excited about the opportunity of working together with Dr. Thakur, Dr. Senna, and all the team, to answer important, to provide important required support to build the capacity and to optimize cryptococcal meningitis care in either hospital and selected facilities. The lessons learned would be provide a foundation for optimizing care across the country.
Okay.
Thank you. Back to you.
Yes, thank you. Thank you so much. Great to have those additional remarks. Again, I want to just make sure people have had a chance to look at the Q&A box with the really interesting questions and the replies from Dr. Raja Singham. I am going to just say I'm very struck that, these low-tech diagnostics, such as a lumbar puncture and India ink, I mean, these have been around for decades. There's nothing digital about them at all. They're quite simple, and it is quite striking that it's such a challenge to have access to them and to use them properly. It's really humbling, actually. We are out of time, unfortunately. We're at the top of the hour, so I want to just thank everybody for attending, for your engagement, for the great questions. As always, the webinar is recorded, and the recording and the slides are posted at the ICAP website. Thank you so much, Radha and Kieran, for these wonderful talks. Really just makes everything more meaningful. Thank you. Okay.